We're going to welcome Dr. Jane Kelly. She is the Assistant State Epidemiologist with the Department of Health and Environmental Services, also known as DHEC, and we are so excited to have her. So we're just going to let her go ahead and get started and have the floor.
Well, thank you so much, and thank you for inviting me. I did prepare a few slides, and I appreciate that you're recording this so that I hope that this has reach that will go beyond our session today. I will also make these slides available to folks because sometimes a picture is worth 1,000 words trying to understand a concept or communicate it. This is our current state of the state. So the blue bars represent the number of new cases per day in South Carolina of COVID-19. The green line is the 7-day average. And that red bar going across, I just wanted to show where we are today compared to previous times over the past 18 months. You can see if you look all the way to the left that we had a surge last year in July 2020, and we're at about the same level of new cases per day as we were then. We had a huge surge, as I'm sure you remember, back in January and February. And unfortunately, a large number of people, especially older adults, people in nursing homes, died. But those numbers radically came down with vaccination. And you can see in late May, early June, we really had hit a low number of cases. We were seeing fewer than 100 new cases per day. And I think that was a combination of mitigation measures with people wearing masks and keeping distances, it being summertime, so people are outdoors more than they are indoors, but also the rate of vaccination. We know we don't have as many people vaccinated as we would like to, but it is increasing each day. Why did we have this huge surge beginning in August and in September? The huge surge relates to several things. One, kids returned to school, so there was more exposure, but perhaps even more important was the Delta variant. The Delta variant is a type of SARS-CoV-2 virus that has several mutations that make it more contagious. It spreads more easily. So we had, again, a huge surge in the number of new cases, but now thankfully it is coming down. It's been quite a roller coaster. Let's talk a little bit about those factors and specifically how it affects different age groups. Most people who get COVID-19, the disease that SARS-CoV-2, the virus causes, most people have mild to moderate illness with fever, cough, maybe some difficulty breathing and some aching all over, but most people do not end up in the hospital with severe disease. Unfortunately, some do. And those who do end up in the hospital usually have disease that isn't just affecting their lungs. This is not just about pneumonia. This is a disease that can cause widespread vasculitis. Any word that ends in itis means inflammation of, like conjunctivitis, arthritis, dermatitis. Vasculitis means an inflammation of your blood vessels. So you can imagine that COVID-19, it can cause not just pneumonia, it can cause heart disease, kidney disease, it can affect your liver, your gut, your brain, basically anywhere where you have blood vessels, you may get inflammation and severe disease. And it's a small number, but a small percentage, I should say, but not a small number of people who end up hospitalized. In South Carolina, we have had over, gosh, I need to look up the numbers before I say how many people we have had hospitalized, but I can say that we have had over 13,000 people die from COVID-19. Now, unfortunately, some of the people who have survived hospitalization have unfortunately gone on to have other complications as a result of COVID-19. And it's true for children as well. Now, this is a slide from what was probably the worst time in South Carolina for children hospitalized with COVID-19. This was about a month ago, Tuesday, September 14th. This is data from the South Carolina Children's Hospital Collaborative. That's 5 hospitals in South Carolina that specifically are taking care of kids seriously ill with COVID-19. The purple dots are kids who were unvaccinated and older than 12. These are kids who could have been vaccinated. The yellow dots are kids who were unvaccinated, but they were under 12 years of age. And you can see the number who were hospitalized because of severe COVID how many were in the critical care unit, and how many people were on a respiratory machine or a ventilator. This is a vaccine preventable disease. And sure, most kids don't develop the severe disease, but this is really a very disturbing trend to see. It's getting better, but we're not out of the woods about this yet. This is data from that same group, 5 hospitals, looking at kids as of this past Monday, October 11th. The number of children in the hospital and seriously ill is lower, but still it's predominantly among kids who were unvaccinated. This is looking at vaccination status for all ages 12 and up in South Carolina, that we have about 61% of people aged 12 and up in South Carolina have had at least 1 dose of vaccine, and almost 54% have completed vaccination. As a nation as a whole, it's much higher than that. It's about 70 to 75%. So we've had an increase in uptake for vaccine when school started, but it's now sort of plateaued. Here it is by age group. So in the youngest age group, 12 through 19, about 30% of them are fully vaccinated, and about the same number for age 20 through 24. And you can see the rates of vaccination increase with increasing age. And I think that's because people with increasing age recognize that they are at increased risk of developing severe disease. But again, I would say when we talk about risks and benefits, even though the risk of severe disease in younger people is much lower, it's not zero. So let's talk more about risks and benefits. But before I do that, let me talk a little bit about what is a vaccine and what can we expect a vaccine to do. Vaccines basically provide a sneak preview for your body. So in this, I like this little cartoon. I think it gives a good image for how vaccines work. There's a wanted poster, shows what the virus looks like. And there are some angry looking white blood cells. They're the ones who make antibodies. And they're angry because they see 2 green virus particles that have entered the respiratory tract. And they already recognize them. They already know that they are bad guys. They need to immediately make antibodies and attack them. So that's what vaccine does. It doesn't prevent the virus from entering your system. It gives your system a jump start on attacking the virus. So anyone, whether you're vaccinated or not, can have the virus enter their respiratory system. If you're in the presence of somebody who has COVID-19 and they cough, or even just are close distance and speaking normally, that virus can enter your respiratory system via your nose or your mouth or even your eyes. But what happens next depends upon whether you're immunized. If you've not had a vaccine and you're not immune, virus particles can enter your cells in your respiratory system, multiply, spread to other cells, and then spread to other parts of your body, especially if you have some other medical condition, either diabetes or being overweight or neurodevelopmental delay, a variety of medical conditions that make you more vulnerable to severe disease. If you're vaccinated and immune, when those viruses enter your system, they are immediately recognized, antibodies attached to them, and then they are literally gobbled up by certain cells in your immune system called phagocytes. Now, this does take a little bit of time, so a person may get some early symptoms of COVID-19, even if they're vaccinated. We'll talk about those breakthrough cases in a moment. But what vaccine does is prevent you from having severe disease, prevents you from going on to being hospitalized and having that need. It'll prevent severe disease. So vaccines provide a sneak preview. Let's talk about what vaccines are available. The Pfizer and Moderna vaccines are really very similar. They each provide about 95% protection 2 weeks after the second shot. Now, for younger people aged 12 through 18, only the Pfizer vaccine is available. Moderna and Janssen are for those age 18 and up. Pfizer now has full FDA authorization. And on October 26th, the Food and Drug Administration is going to review their vaccine for kids ages 5 through 11 years. And the preliminary data on that looks good. Looks like, again, Pfizer provides 95% protection against symptomatic disease, even in that younger age group. It's a smaller dose. It's 10 micrograms instead of 30 micrograms. What about the Johnson & Johnson vaccine or Janssen vaccine? Johnson & Johnson is the parent company. They make lots of different products. Janssen is the part of the company that makes specifically this vaccine. This vaccine is given as a single dose. And as a single dose, it provides 85% protection against severe disease. They are also being reviewed this week for whether FDA will authorize them as a 2-dose vaccine. So 1 dose give you 85% protection, but their studies have shown if you get a 2nd dose of Johnson & Johnson, it too will give you 94% protection. So it's right up there with those other vaccines. Right now, it's only available as a single dose, but I think in 2 weeks from now, it'll be available as a double dose. So for each of us, we have to make our own personal decision. What are the benefits? Well, vaccines are highly effective. These are some of the most effective vaccines that we've ever had compared to the risks. And I think the risks you think about, we're going to talk a little bit about what are the risks of getting vaccinated. But I think you also have to compare to the risk of getting COVID-19 disease. For each of us, that's what is your risk of even getting the infection? You know, how much are you interacting with others? Do you have a job where you're interfacing with the public where you don't know their vaccine history? And also personally, what's your risk if you got COVID-19 of having severe disease? You know, are you older or have any of those medical conditions? Well, let's talk about some of the common misconceptions and fears, because when we talk about risks, and I'm talking about risk of vaccination, I think of that as, well, what's my risk of getting an allergic reaction? Well, it's about 1 in a million for these vaccines, of a risk of a severe allergic reaction. So that's pretty low. That's lower, in fact, than the risk of getting an allergic reaction to penicillin. What about the symptoms that you might feel after vaccination? Well, we have a lot of experience with this right now, right? We've had almost 400 million doses of vaccine given in this country alone. And we know that most people do experience sore arm, achy all over, not feeling great for a day or two. But for most of those people, it's mild to moderate. And the third risk you have to think about are rare conditions. There have been remarkably few rare conditions around getting COVID vaccination. What there have been a lot of, though, are rumors. Let's focus on these rumors. One of them is COVID vaccine and fertility. Now, if we go back to the original studies, of course, in the original studies, they did not enroll anybody who was pregnant. They deliberately excluded anyone who was pregnant. But I can say that, for example, during the Pfizer vaccine study, there were 23 women who volunteered and were given the vaccine or given the placebo who turned out to be pregnant during the study, unintentional pregnancies. The only one who had a miscarriage was a woman in the placebo group. But I know that's a small number of people. So, you know, that's not very reassuring. When we first were giving out this vaccine, it was hard to say whether it might have some effect during pregnancy. Theoretically, it would not, but we didn't have any evidence. Now we have some evidence. I'm going to skip ahead to this and return to that other one. When you get vaccinated, you're offered the opportunity to enroll in something called V-Safe. And this is a module where the CDC is going to send you a text message every day for a week, and then every few weeks for another 6 months. And if you sign up for V-Safe and you're pregnant, they have an additional special pregnancy module where they contact you and ask a bunch of pregnancy questions. They ask how you're feeling, but they're also asking, you know, have you had a miscarriage? Have you had any complications? You know, what is happening in your pregnancy? Over 35,000 women who were either pregnant when they got vaccinated or got pregnant shortly after they got vaccinated signed up for this. And CDC has analyzed the results. So more than 35,000 women. They ranged in age from 16 to 54. It included a variety of race, ethnicities. And again, these are people who were pregnant or got pregnant shortly after they were vaccinated. What happened to them? This is a slide that shows what happened to them. On the left-hand side where it says participant reported outcomes, it lists something called spontaneous abortion. That's the medical term for a miscarriage. And we have a lot of data going back for years on pregnant women. So that middle column where it says published incidents is, what do we know from years of experience? How many women have a miscarriage, or how many women have a preterm birth or some other complication? It ranges because there's a wide range from 10 to 26%, because it varies with the age of the mother, it varies with access to medical care and some other issues. But it's about 10 to 26% of pregnancies normally, and unfortunately in a miscarriage. In the V-Safe pregnancy register, 12.6% of those 35,000 women had a miscarriage. So it's in that same range. There was no increase in miscarriage, stillbirth, premature birth, small babies, etc. Now, where did this rumor about fertility come from? That's where I want to go back to this slide. Where did the fertility rumor begin? Well, in December 2020, just as in this country, the FDA was trying to decide whether to approve Pfizer and Moderna vaccines, the same thing was going on in Europe. And two people wrote a letter to the European equivalent of the FDA, a physician who was an ex-Pfizer employee and another physician. And they wrote a letter claiming that the spike protein on the outside of the virus, that's the protein that attaches the virus to the cell to get the virus into the cell. They claimed that that spike protein is similar in structure to a protein in the placenta. And if a woman got vaccinated, she'd make antibodies to the placenta. Now, number one, there's no evidence this is true. And I just showed you the data on 35,000 pregnant women. If they made antibodies to the placenta, you would expect a higher rate of miscarriage. And I'm going to get a little bit complicated in the weeds because sometimes people want to know where this rumor came from. But what they said in their letter is that they had the spike protein and this placenta protein had a sequence, a series of 4 amino acids in common. But that's out of over 500 amino acids in that placenta protein and out of over 1,200 amino acids in the spike protein. So I just want to put to bed the concern about if you're pregnant, you shouldn't get vaccinated. There's no increased risk of having a miscarriage if you're pregnant. On the flip side, there's a much greater increased risk of, if you get COVID when you're pregnant, of having serious disease. We'll talk about that in a moment. So why are vaccination rates so low in the younger adults, not just 12 through 24, but the 30s and 40s as well? I think a lot of it is fertility fears. So I just showed you the pregnancy, no increase in miscarriage data. Let me talk to you about 2 other things that were just very recently published. This is new data. One is looking at unintended pregnancies, pregnancies where the woman wasn't definitely trying to get pregnant. Unintended pregnancies occur at the same rate in vaccinated as in unvaccinated women. And that's not just with the COVID vaccine, that's been true with other vaccines as well, including other messenger RNA vaccines that have been done in other countries. For vaccines that we don't use in the United States, but vaccines like Ebola or the Zika vaccine, there's been no change in the rate of unintended pregnancies. There's also interesting information out of fertility clinics. So these are people who do already have a problem with infertility. They're trying to get pregnant. There was no difference in successful frozen embryo transplant. It was trying to take a baby who had been fertilized in vitro and implanting it in the uterus. No difference in successful rates of doing that, whether the woman had SARS-CoV-2 vaccine, had previous SARS infection, or someone who had neither one. So there's no decrease in fertility with COVID vaccine. In contrast, there are a lot of studies showing an increased risk of severe COVID in pregnancy. And I'm just going to show you one of them. This is a summary of many of those studies. It's what's called a meta-analysis looking at pregnancy outcomes. And there is a double, 2 times higher risk of stillbirth, 3.5 times higher risk of the baby going to the neonatal intensive care unit if the pregnant mother has COVID, almost a 5 times higher risk of the mother going to the intensive care unit. So bottom line, COVID is a bad disease in pregnancy. And I know that the American College of OBGYN and multiple other medical organizations highly recommend getting vaccinated if you are pregnant or trying to get pregnant. I do want to say a little bit about male fertility as well. So number one, the COVID vaccines have no live virus. You can't get COVID-19 from any of these vaccines. All the vaccine contains is the gene for that spike protein. So you can't get the COVID disease. What you make are antibodies to that spike protein so the virus can't get into your cells. Now, this study in the Journal of the American Medical Association looked at 45 healthy men and did sperm counts, movement, concentration before and after COVID vaccine. Now, I know that's a small number of people, but just to say there was no difference before and after vaccine in these men. I want to put this in contrast to what a virus can do to your system. It's been known for decades that the mumps virus can cause infertility. Mumps doesn't just cause swelling of salivary glands, it can affect the testicles as well. And it's been shown definitively that the measles, mumps, and rubella vaccine, the MMR vaccine, not only prevents mumps, it protects against infertility in men. Now, what can we say about COVID-19? Well, it's going to be a long time before we have a lot of information on male fertility. What we know right now is that for men who are vaccinated, there is excellent evidence that prevents them from getting severe COVID-19. There is evidence that COVID-19 disease can cause infertility. That virus that causes COVID-19 disease can also cause, just like mumps, an inflammation of the testicles. Neither the MMR nor the COVID-19 vaccine cause infertility, but they do prevent the virus infection that can cause infertility. I'm just giving you a lot of references here. Again, that this is not my opinion. There is increasing evidence about viruses and fertility. SARS, which was a cousin, that was the original severe acute respiratory syndrome. That was a closely related virus that infected people in 2003. We have a lot of data on that. The people that it infected, it definitely caused testicle inflammation and sperm abnormalities. And we have some evidence of changes in male hormones, both with the original SARS and with this new SARS-CoV-2. So a number of different societies around fertility and reproductive medicine all recommend vaccination against COVID-19. So when you weigh risks and benefits, I think you also, if you're concerned about fertility, then you have to also look at what's the evidence. The evidence is strong that COVID vaccines do not cause infertility. And the evidence is there also that COVID disease can cause pregnancy loss and may decrease male fertility. Now, I know the other big one I hear a lot about is concern about myocarditis. This is an inflammation of the heart muscle, and this has been associated with COVID vaccine. But let's talk about this in terms of its risk, which varies with gender, whether you're male or female, and age. And right from the start, I do want to emphasize there have been 0 deaths associated with COVID vaccine and myocarditis. This is a table. I just want you to know where this data is coming from, that this was a publication looking at by age and by gender, male versus female, of the risk of getting COVID-19 and what it might cause, because that's going to vary. Older adults are more likely to have serious disease, younger adults much less likely. But also, what is that risk of that myocarditis or inflammation of the heart muscle? And they've divided it out by different age groups. This is a challenge, I think, to understand this table. So I'd like to put it in a different context, because they're saying, for example, for people age 12 through 17, that you'll get 56 to 69 cases of myocarditis per million doses of vaccine. I find it hard to think in terms of million doses of vaccine, so I've got a little different visual that I find a little bit easier to grasp. Let's visualize a stadium of, say, 80,000 boys, all ages 12 through 17, and they're all vaccinated. About 5 to 6 of them on average would experience myocarditis. And the myocarditis they would experience is mild, it's temporary, and it's treated with non-steroidal anti-inflammatory drugs. That's things like ibuprofen. Often doctors will hospitalize these kids just to put them on a heart monitor to watch them for any irregular heartbeats. But again, we have not had anyone die of vaccine-associated myocarditis in this country. More than 95% have completely recovered. That other 5% are people who are currently experiencing myocarditis. In contrast, let's have another stadium. 80,000 boys, same thing, age 12 through 17, who are not vaccinated. On average, over the next 3 months, about 456 of them would get COVID. 18 of them would be hospitalized for severe COVID. 6 of them bad enough that they're in the intensive care unit. And there would be fewer than 1 death, but there would be 0.2 deaths. That's not 0. That's less than 1, but this is a vaccine preventable disease. This is something where we could prevent all of these red circles. Let's talk a little bit about breakthrough cases. The definition of a breakthrough case is someone who has been fully vaccinated, yet comes down with COVID-19. They are exposed to the virus, breathe it into their respiratory system, and they experience COVID-19. This is rare. For example, here was a study looking at healthcare workers, people who are exposed all the time at work to SARS-CoV-2. They're frequently exposed to the virus because they're taking care of sick people. So they looked at what was their rate of getting infected after vaccination. And they found that looking at over about 4,000 people, those who were fully vaccinated were 90% less likely to get infected than those who were vaccinated. So this was evidence that vaccine definitely works to help prevent infection. But let's look at some data specifically to South Carolina. We've had over 2 million people fully vaccinated in South Carolina, and we've had a little more than 10,000 breakthrough cases. So 10,000 sounds like a lot, but 10,000 out of over 2 million fully vaccinated people. And what about those 10,000? How many of them had severe disease or died? Well, about 900 of them had to be hospitalized. Again, that's out of over 2 million people. And there were 256 breakthrough deaths. Who were these people? Most of them had severe immunocompromised. They're people, for example, who have had a kidney transplant and are on immunosuppressive drugs, or they're people with multiple medical problems. The average age of people with those breakthrough deaths, the average age was 80. So breakthrough cases are rare. Vaccines do keep you out of the hospital, out of the morgue. What about if you've already had COVID-19 disease? Do you need the COVID-19 vaccine if you've already had COVID? Well, certainly if you've already had COVID, your immune system's been exposed to COVID, you have a certain degree of immunity. It varies from person to person. People who had mild disease or less have lower antibody levels in response to the virus than people who had severe disease. But I think the more important question is there any benefit? Do you get any extra benefit by getting the vaccine after you've had COVID? And the answer is yes. If you already had COVID, you can cut your risk of reinfection in half by getting vaccinated. How do I know that? I've included just 2 links to 2 studies. One was in Kentucky, where they were looking at people who were infected and then reinfected a year later, compared whether they got vaccinated or not. The vaccinated group had less than half the number of reinfections than the unvaccinated group. And the other one is a big study in Israel, where they are looking at millions of people who were vaccinated who had prior COVID versus unvaccinated. You can cut your risk in half by getting vaccinated. I want to say a little bit about boosters and third doses of COVID vaccine. The third dose of COVID vaccine is an additional dose. Remember, I mentioned the immunocompromised people, for example, with a kidney transplant, they don't have as strong a response to the original 2-dose series. So it's recommended that they get an additional dose of vaccine to try and give their immune system a little bit more strength. A booster dose, though, is to boost immunity for people who did respond, but whose immunity is now starting to wear off. And so again, third dose for people who are immunocompromised, people with cancer, people who had an organ transplant, or people on prednisone, 20 milligrams or more. But the whole boosters for everyone, it really varies with the situation. And unless you think that boosters mean vaccine doesn't work, I've included this busy slide. This busy slide is showing the vaccine recommendations for children on the top and for adults on the bottom. And if you look at the kids' vaccine schedule, parents, kids get a lot of vaccines and often they need to get multiple doses before they're fully vaccinated. Like look at the third row there, diphtheria, tetanus, and pertussis. They get that vaccine at 2, 4, and 6 months, and they get a booster between 15 and 18 months, and then another booster at 4 to 6 years of age. And then for the rest of us, we get our tetanus boosters about every 10 years. Boosters don't mean that the vaccine doesn't work. Boosters mean sometimes you need reminders for your immune system. So what are the recommendations for boosters for the Pfizer vaccine? The recommendations for Pfizer for people who are 65 and older should definitely get a booster shot at least 6 months after their primary series, as well as people in long-term care settings, not just older, they may be younger people in long-term care settings because they're just more vulnerable. And also people aged 50 to 64 who have certain underlying medical conditions like diabetes, heart disease, liver disease, kidney disease, or even people who are simply overweight or obese. They're at higher risk of severe disease. But the recommendations also include a recommendation for people who may receive a booster, and they can base that decision on their individual benefits and risks, perhaps talking with their pharmacist or their healthcare provider. So anybody over age 18 who has high risk because of underlying medical conditions, they might want to get a booster vaccine. The vaccine dose for the booster shot for Pfizer is the exact same dose as with the first and second dose for Pfizer, and it's a little bit lower for the Moderna dose. Moderna is undergoing review by FDA right now, so it's not available yet, but the Pfizer dose is available for those who've received the original Pfizer series. The last category are people who are at increased risk of COVID-19 exposure. They don't have medical conditions, they're under age 64, but they're teachers or they're nurses, or there's someone who is working in a grocery store where they feel like they're exposed all the time to other people. They may want to get a booster dose. How long does a booster dose last? Well, that remains to be seen. It might be that people will only need one booster dose. On the other hand, it may be if we get new variants that emerge, we may have escape mutations and might need to make another vaccine, similar to the way we do it with the flu shot, where you get an annual flu shot. So, for example, to give you a scenario, so what if a teenager got his first vaccine and then got COVID and was due for his second shot? When should he get vaccinated? He should get vaccinated as soon as he's finished his isolation or quarantine. So I know there's been confusion about when do I get a booster? When do I get our second shot? We have a lot of information specifically about this sort of thing under our FAQs, frequently asked questions, on our DHEC website. So just to summarize, Pfizer, booster dose, 6 months after your second dose. Moderna, they're looking at that this week, but probably it would be the same recommendation as Pfizer. The Johnson & Johnson, they also have submitted a booster application, and FDA is looking at it this week. probably that too will get approved as getting a second dose, but the exact timing is going to remains to be seen. It is recommended that you don't mix and match. Like if you got Johnson & Johnson, don't go out and get a Pfizer dose now. Just wait. I mean, I think we will have answers to these questions within the next 2 weeks. In terms of vaccination timing, once upon a time in the very beginning, we were saying, when vaccine was scarce, we were saying, if you had COVID-19, you can delay getting vaccinated so that we can make that scarce resource available to others. Because we know that reinfection is rare within 90 days of infection. We now have plenty of vaccine. Our supplies are greater than the demand. So once again, in terms of when to get vaccinated, if you're infected, if you had COVID-19, you have to finish your isolation, or if you're in quarantine, you have to wait until that's over. But then you can get your second dose of vaccine or a booster dose if you're due for it. The most important thing to know about the Delta variant is that while it does spread more easily, vaccines do work against the Delta variant. All 3 of these vaccines are effective against the Delta variant. And Delta right now is not literally 99% of the new cases that we are seeing in South Carolina. And it's more than 90% everywhere in the nation. So the Delta variant spreads more easily, number of cases are coming down, but I think it's still an important tool in our toolbox to get vaccinated. And as long as we're talking about vaccine, the flu season is upon us, and we would also highly recommend getting a flu shot. I'm going to linger here on my email address. I will send the slides out, but so that you have my email address, if there are any questions that are not answered during this session and you wish to contact me, please feel free to do so. My email is kellyjm1@dhec.sc.gov. I'm going to stop sharing my screen and see if we have any questions.
Thank you, Dr. Kelly, for that. That was just good information, All right, so right now, I know you guys have questions and you're getting your typing fingers together, but in the meantime, we do have a few questions that we just wanted to ask. Just wanted to clarify about, I know we talked about pregnant moms, but what about nursing moms? Moms who are nursing and they are getting the vaccine. Will that pass through breast milk? Is that good, bad, or?
Excellent question. So the vaccine itself does not go through the placenta in pregnancy, and the vaccine does not come out in breast milk. What does come out in breast milk, though, are antibodies. So vaccine goes into mom, whether she's pregnant or nursing. And not only does she benefit, the baby benefits, because the pregnant mom will pass those antibodies on to the baby. Those antibodies won't last forever, but they'll last for the first few months of life. But if she's continuing to nurse, her antibodies will pass in the breast milk. So that's called passive immunization. It's a way to help keep your newborn safe.
Thank you. Okay, and we do have a few questions in the chat. So first question is there anyone in particular who should not get the vaccine?
Yes, there are very few contraindications to the vaccine. The main contraindication is an allergic reaction to one of its ingredients. So the ingredient in the Pfizer and Moderna vaccine that some people are allergic to is something called polyethylene glycol. It's a common ingredient in over-the-counter laxatives like Colace. So a person who maybe had an allergic reaction to, the colonoscopy medication, for clearing their gut, that's a person who shouldn't get Pfizer or Moderna, but they could get the other vaccine, the Janssen vaccine, because that does not have polyethylene glycol. The other ingredient in the Janssen vaccine that sometimes causes an allergic reaction is something called polysorbate 80. And it's a common ingredient in salad dressings, in ice cream, and a lot of foodstuffs. So again, it's a rare person who's going to be allergic to one of those ingredients, but they would know that. The other contraindication is if you got like your first dose of Pfizer and Moderna and had a severe reaction, you don't want to get the second dose of that. But that's something where you want to confer with your doctor. But other people with medical conditions, heart disease or lung disease, I mean, they're the ones that it's most important to vaccinate. People with autoimmune diseases like lupus, they're the most important ones to vaccinate. And having those diseases is not a contraindication to getting vaccinated.
All right. Thank you for that. All right. So the next question we have, just to be sure, boosters are not currently recommended for ages 12 to 17.
That's right. Boosters are not currently recommended for that age group, but we have time to decide on that because those vaccines were not available to them until this summer anyway. So we've got time to sort out whether they should get boosters 6 months after their second dose. But that's not, that 6-month point is not going to come up for another probably, 3 to 4 months at this point. So no boosters for that age group as yet. The boosters are only for ages 18 and up. It may be the kids in that age group, they have a really strong immune response. It may be that they won't need boosters at all.
Okay, all right. All right, so the next question we have, on the CDC website, it states that reports of adverse events to VAERS following vaccination, including deaths, do not necessarily mean that a vaccine caused a health problem. So the question is, what is being done to find out more information about the cause of these deaths?
So let's talk about VAERS. VAERS, VAERS, stands for the Vaccine Adverse Event Reporting System. The way that works is anyone can submit a report to VAERS. So for example, if you got vaccinated or your child got vaccinated and you thought that they had some sort of a reaction to the vaccine, it might be days later, you can report it to VAERS. What they're doing is they're looking for anything that might, is a trigger. Like we're seeing more of this particular complication, we need to investigate it. With regards to deaths, though, they have a more rigorous system. So as a physician, I am required by law, if I have a patient who has died and been recently vaccinated, even if I don't think it was related to the vaccine, I'm still obligated by law to report that. So for example, I'm an emergency room physician and there's a car crash and the patient comes in, severe trauma and dies. But I know that, but in the record, it says they were vaccinated a week, 2 weeks ago. I have to report that to VAERS. Now, was that car crash related to being vaccinated? Well, CDC will investigate it. They investigate all deaths. When I say investigate, they will look at the death certificate. They will look at any medical records. If the person was in the emergency room or hospitalized or died in a nursing home, those will all have medical notes. If they died at home, they may have an autopsy and they would have those autopsy notes as well. And they review that to look and see if there was some sort of link. That is how they found out, for example, about the myocarditis, because those myocarditis cases are really pretty rare. I shouldn't mix that in with deaths because there have been no deaths from myocarditis. But I just wanted to make the point that that's how they first started to look into it, because they said, we always have a certain background rate of myocarditis in the United States. Myocarditis comes from many causes, from viruses, it comes from autoimmune disease, sometimes as a medication reaction, but they noticed that there was a higher rate among people receiving vaccines, so they investigated it. With regards to deaths, the only deaths that have been shown to be associated with vaccine is that blood clot with low platelet count syndrome associated with the Johnson & Johnson vaccine. The CDC had received about 16 reports of this strange syndrome called thrombosis with thrombocytopenia, strange syndrome of blood clots and low platelets. Now we're talking they had 16 reports of this, and yet they investigated it, found that they increased the number of cases found to 25 there were 3 deaths. Those 3 deaths were before this syndrome was recognized, and they were treated with medication that we know today would not be the best treatment for that syndrome. So in answer to your question about VAERS, you read, what does it say on the CDC disclaimer? They're basically saying everything gets reported, and they do definitely investigate anything where they think there's been an unexpected increase in a complication, and they investigate all of the deaths.
That sounds great. Thank you for answering that question. I'm sorry, I lost my mute button for a second. So another question that came up, I know you talked about the vaccines working against the Delta variant. Are there any other variants that we should be concerned of outside of Delta that maybe the vaccine may not be effective against?
There is the variant called the Mu variant, that's MU. Each of these variants is named after a different letter in the Greek alphabet. The Mu variant is less than 1% of all the variants in the United States, and Delta seems to outcompete it. It doesn't spread as easily as the Delta variant. The Mu variant is considered a variant of I'm trying to think of the term. It's not quite variant of interest, but it's a variant being monitored. Variant being monitored by CDC, because there is some question that it might not be as it might be more resistant to the vaccines. We don't know that for sure yet, and right now it's still a very small number of cases, but that it's being followed.
All right. Well, are there any other questions? I think we've gone through the ones that were in the chat. Anybody else have any other questions? Make sure you keep those typing fingers going. I don't want to squelch anybody's questions that they may have.
Where is the Mu variant currently in the US? I see. The Mu variant, I think, was first found in California. And I think it is 0.2% of new cases in California. Viruses mutate for a living. There are always going to be new variants. So just because there's a new variant doesn't necessarily mean it's something to worry about. It's being monitored because there were some questions about its structure in the spike protein. Maybe it'll be able to evade the vaccine. But if it turns out, for example, if it turns out that we get a variant for which the vaccines don't work as well, the vaccine companies have the technology to change those vaccines quickly. I didn't talk very much about what is different about these vaccines and what is an mRNA vaccine or a messenger RNA vaccine. But if we've got a few minutes, I think it's helpful to understand how these vaccines are made. Because I know people are afraid also that, these vaccines seem too new, they were developed too quickly. And I don't think that tells really the whole story. I mentioned SARS, severe acute respiratory syndrome. That was back in 2003. About 8,000 cases, about 800 people died, and it was a pandemic. We had cases in the United States, but it wasn't anywhere near as contagious. It didn't spread as easily. So public health, they were able to contain it, and we really have not seen any cases of SARS since then. But there was a lot of concern in the scientific and public health arenas that this is going to come back. This virus is going to come back, and it did. It came back in 2013 as MERS, Middle Eastern Respiratory Syndrome, which people may not have even heard of because it really didn't affect us here in the United States. It was more in the Middle East. But they started working on a vaccine back in 2003, studying what is this virus's structure? What are its weak points? And they even did the genomic sequence, looking at its exact genetic code. They sequenced it all the way out so that they knew exactly how its genes were lined up. Then when SARS-CoV-2 came on the scene, they did the exact same thing. They did its gene sequence. This is molecular biology, but this is a dramatic change in medicine and in science that they were able to do that because they're literally able to line up side by side the genetic code of the original SARS and the SARS-CoV-2 to see where they differed. And then they picked that spike protein. There's been research going on the spike protein for years with the original SARS, but they could look at those two side by side, figure out what's different in the SARS-CoV-2 spike protein, and make a vaccine specific to that. The reason that's a revolution is the old way of making a vaccine is to take a virus or a bacteria and then weaken it or inactivate it or kill it, and then inject that as a vaccine. So your body makes a reaction to the whole virus. The problem with that is that if there's a mutation so that it's no longer weakened and inactivated, the problem with that old method is then you might actually get the disease. So this is a much cleaner way of making a vaccine. There's no whole COVID virus in any of these vaccines, just the gene for that one part, the spike protein that helps the virus get into the cell. So what they can do is if a new variant comes along that these vaccines are not as effective against, they can look at the genetic code. I mean, that's how they decide this is a new variant. They look at the exact gene sequence in the mu variant and the Delta variant, see where it is different. And then they can take that and they can tweak their vaccines to be more effective. Right now, they don't need to do that because the vaccine has been effective against all the circulating variants. But if a new one came along, this new technique in making a vaccine would be very amenable to changing the vaccine in a timely fashion.
Thank you. Thank you for that answer. That really kind of gives a lot of clarity into why this vaccine was developed so quickly. Well, not technically quickly, but it gives a lot of insight into why it seems like it was developed overnight, but it really wasn't. The next question that we have is, are masks here to stay? Meaning, when cases are still low, do we still need to wear masks? When will we not need them?
I think that we may have a little bit of a culture change in the United States around masks. You know, if you travel in other countries around the world, travel in Asia, people often wear masks. And it's not just because of air pollution or dust. If they're sick, even with just a cold, to protect others, they wear masks. Or if they're know that they are vulnerable because they got medical conditions, they know they're going to be in a crowded place. Sometimes they'll wear a mask to protect themselves. That it may end up being true in the United States as well, that some people will choose to wear a mask, especially in the winter months, protect them against influenza and other respiratory diseases. But I do not think that we are going to always be having this issue with kids in schools wearing masks and you can't go to a music venue without wearing a mask, et cetera, et cetera. This is not going to last forever. I don't think COVID-19 will go away completely. I think we're not going to eradicate it like polio or smallpox. I think it will become endemic, meaning always around. However, I think once we have people either vaccinated or they've had COVID-19 and they're vaccinated, we'll build up enough immunity that we won't have as many people with severe disease. It'll be more like a circulating respiratory virus that's a hassle rather than a killer.
Okay, thank you. And in the last few minutes, y'all have put on your chatting fingers. So we have a few questions that popped up. So I'm gonna go from the most recent one. What could be the possible reason for severe illness and or deaths among those who have experienced breakthrough cases? And with a follow-up question, and what is it about the Delta variant that causes it to spread more easily?
Most of those breakthrough cases that died were either quite elderly. I think I mentioned the average age in South Carolina of those who died with a breakthrough case was 80. And most of them had immune conditions. You know, most of them had either an autoimmune disease where they're on powerful medications, for example, for rheumatoid arthritis, or they've had a kidney transplant or other organ transplants. So they're on immunosuppressives. So unfortunately, vaccine just does not take as well in those individuals. And in terms of, now I've forgotten what the other question was. What was the other question?
What is it about the Delta variant?
Delta variant.
To spread more?
The Delta variant on that molecular level, it ends up, it can attach to the cells in your respiratory system with greater, what they call avidity. It's more avid, it attaches better. Its spike protein attaches better, so it can inject the virus RNA into the cell more effectively. And it causes higher viral loads, meaning the higher amount of virus that you're carrying in your respiratory system when you're infected. So those are two reasons why it can spread more quickly That's one reason why it can affect you. You would catch it more easily because it attaches better, and why you could spread it to others more effectively because you get a higher viral load.
Okay. Next question we have is there any truth to rumors of the vaccination causing AIDS or Parkinson's disease?
I've not heard rumors of it causing AIDS. I wonder if that's because the structure of the HIV virus has some similarities to the structure of the SARS virus. They're very different. They're in different virus families, but a lot of viruses will have the same pattern for certain things, like, making their protein coat. They'll use like the same amino acids over and over again. But there is no evidence that the virus can cause AIDS, or any evidence that vaccination can cause AIDS. I hadn't heard that rumor before. And in terms of Parkinson's disease, certainly when a person is vaccinated, it can give them a lot of different symptoms, that aching all over, or, feeling sore all over. And that can bring out symptoms that had been more subtle before. Like if a person has Parkinson's disease, that their tremor might get worse shortly after vaccinated, but that should not be a permanent effect. There's no truth to the rumors that vaccination can cause AIDS or Parkinson's disease. The vaccine does not use any cells or whole virus. So that's just a sheer rumor. I'd like to hear where that rumor is coming from. I see the other question, J&J vaccine doesn't have mRNA made from an old adenovirus. Can it still be tweaked? Yes, you are correct. The J&J vaccine is a different methodology. What they do is they take that same gene for the spike protein. So there's no whole COVID virus in here, just the gene for the spike protein. But they use a weakened common cold virus, an adenovirus, as like a delivery truck. Because adenoviruses, as we know, are very good at getting into your respiratory system. So they attach that gene for the COVID spike protein to the adenovirus, put it in a vaccine. Adenovirus, it's like shelters that spike protein into the cell. And yes, it can still be tweaked, because the most important part is that gene for the spike protein. And that will be tweaked the same way as with the Pfizer and Moderna. And I see, do I have any information I can share about Novavax? Novavax is another vaccine that is going through phase 3 studies and looking very successful. It's a different approach altogether. It does not use the gene for the spike protein. It uses the protein itself. So it's a different way of making a vaccine. So there's no messenger RNA and no mRNA in that, no genetic information at all, just the spike protein. It's kind of more of an older way of making a vaccine, but for people who, don't like the idea of getting an mRNA vaccine, maybe they would find this more reassuring. And the other advantage of it is it doesn't have to be kept super frozen. So it's a little easier to handle. So it might be an important vaccine in some other countries where they have trouble, or countries in Africa, for example, where they may have trouble keeping what's called a cold chain, keeping the vaccine cold.
What is the best way to locate where to receive vaccines in your community?
The DHEC website has something called a vaccine locator. So if you just type in Google Vax Locator, VAX Locator, DHEC, it will take you to a page where you can enter your zip code, or you can let the computer figure out where you are. And then it'll give you a list of not only all the different locations where you can get vaccinated and how far away they are from you, it'll also give you a list of which vaccines they offer. So for example, for me, I can type it in and I know my local Harris Teeter has Pfizer, Moderna, and Janssen. Some locations only have 1 or 2 vaccines. So it's worth your while to look at that Vax Locator, and you can choose where you can get vaccinated. And also, thank you, you've put the email address in the chat box. That will also indicate to you when you can make an appointment. And right now, there are plenty of appointments available. Where could we find the suggested vaccination chart for children and adults you shared? I took that directly from CDC. So again, if you just do vaccination chart, CDC, that'll bring you to that. And we will be sharing this presentation, so you'll also have that slide.
Yes, Suzanne will send a copy of the presentation to everyone as well, so you can use the information in the presentation.
And I'm glad you mentioned that, because I think especially with the pressures of this pandemic, a number of kids have fallen behind on their immunizations. Parents were stressed. They didn't want to bring them to the pediatrician's office. They're afraid of getting an infection. And so they kind of put off some vaccinations. But there are ways to catch up on vaccinations as well. And so I would urge people to, talk to your pediatrician, look at what the vaccine schedule is, and see if there are some catch-up vaccines that you need to get.
Dr. Kelly, could you speak to some of the reports that I've seen about blood clots in women who received the Janssen vaccine?
Yes, it is true that there have been 3 deaths in this country associated with vaccine. Those 3 deaths were not from severe allergic reactions. Instead, they were from a rare syndrome called thrombosis with thrombocytopenia. That means blood clots with low platelet count. That's a really rare, unusual phenomenon. And they had blood clots, not just simply like the blood clot you might get in your leg, or a blood clot associated with having a stroke. No, they had really weird distribution of blood clots. They had blood clots in the blood vessels that go to the intestines, for example. But it was only, I'm sorry to say only, because any death is a tragedy, but they were 3 associated with the Janssen vaccine, 3 out of more than 15 million doses of vaccine that was given. Now that we know more about this rare event, there is a test the physicians can do for it. Part of the reason that the Janssen vaccine was placed on hold was to look for more cases so it could be studied and understood better what was happening and how to treat it, and to educate physicians on it, how to test for it, how to recognize it, and what is the correct treatment from it. We have not had any further deaths from that syndrome since that time. Share warning signs for such a reaction: severe headache, severe abdominal pain, and anything that looks like the warning signs of a stroke, such as slurred speech, weakness or paralysis in a limb, or altered consciousness, person being confused. I think these are all things for which someone would visit an emergency room anyway. These are not mild symptoms. But I think in the very beginning, it wasn't recognized what was going on. The situation would be perhaps an older adult gets vaccinated with the Janssen vaccine, shows up looking like they're having a stroke. They got treated as a stroke, and it wasn't recognized initially what was going on. And that's what led to those 3 deaths, because this was a new syndrome and it just wasn't recognized.
What about warning signs of myocarditis in teens? As the mom of 2 teen boys, I worry about that.
Sure. So not to dismiss myocarditis, but myocarditis is not only associated with this vaccine. Every year in the United States, we see about 70,000 cases of myocarditis, because it can be caused by viral infections, can be caused by autoimmune disease such as lupus, it can be caused by certain medications. So every year we see about 70,000 myocarditis cases. Most myocarditis cases are not severe. Most myocarditis cases, they do put in the hospital to monitor the heart rate for a few days, just to make sure there are no rhythm abnormalities. What are the symptoms that would go with myocarditis? Chest pain, shortness of breath, shortness of breath on physical activity. Your young, healthy teenager is short of breath walking up the stairs, or no longer can keep up with the track team or cheerleading or whatever they normally do. So those are the three cardinal symptoms: chest pain, shortness of breath, and fatigue, unable to keep up with their usual level of physical activity. And there are specific tests they can do for it. I mean, if you brought your child in to see a physician, or you brought them into urgent care, what they would do is do an EKG, and they can do some blood work to diagnose it. It's not that hard to diagnose.
Thank you. Last call for any questions in the chat here with Dr. Kelly, or if you're unable to type in the chat, let me know. If there are no other questions, we can maybe give you 5 minutes back of your evening. I'll just wait one more minute to make sure that nobody else has any other questions.
I know a lot of people are hesitant about this, 5 through 11. It's like, really, should I vaccinate? I thought the children have such low risk. And I would have to say they do have low risk, but it's not zero risk. And what we're seeing with the vaccine is, with almost 400 million doses of vaccines administered in the United States, more than 200 million doses of Pfizer vaccine administered, there have not been a lot of safety concerns. I know I mentioned the myocarditis, and that is a concern, but no one has died of myocarditis. It's been treatable, and they've recovered. And in fact, there is some history of myocarditis with other vaccines. Smallpox vaccine. The smallpox vaccination caused myocarditis at about the same rate as this Pfizer vaccine. Now, smallpox may seem like ancient history vaccination to you, but in fact, in the years 2001, 2002, over 2 million military recruits were vaccinated for COVID-19 because there was concern about bioterrorism. This was post 9/11. There was concern about bioterrorism. Over 2 million, mostly male recruits, got vaccinated with smallpox, and about 16 per million, they're mostly young guys, 16 per million got myocarditis. And now here we are 20 years later, they have not had a higher rate of other heart disease than just sort of the background rate of people in their age and gender group who were not vaccinated for smallpox. I see another question: how long after receiving a vaccination should you monitor yourself or your child for symptoms? It is common for people to have the symptoms of sore arm, aching all over, fever, chills, just feeling lousy, wanting to go to bed, but that should not last longer than 2 or 3 days. If you have a severe headache or severe headache that does not respond to Tylenol or ibuprofen, that's a reason to see someone. If you're feeling achy all over and it's so severe that that doesn't respond to Tylenol or ibuprofen and you can't get out of bed, that's a reason to see someone. But most people do, like more than 90% of people get a sore arm with the vaccine. But that's true with lots of vaccines. That's because your immune system is responding to the site where the vaccine was given. That's a good sign. I'm not so much worried about that. But these other conditions, the symptoms that last 2-3 days, then it should stop. In terms of this myocarditis, almost all the cases of myocarditis occur within the first 2 weeks.
Thank you so much. It does look like it's 7 o'clock now, so we will go ahead and wrap up. Again, thank you, Dr. Kelly, for being here and answering all of our questions twice today and giving up so much of your time for us. And again, Suzanne will send a follow-up email with a copy of the presentation, and Dr. Kelly's contact information is on there as well if you have any questions after the presentation.
Great. Well, thank you so much for doing this. It's so important to get the word out. And, I like to ask a favor of those listening to this, and that is share your information, share your experience. You can share this presentation, you can share these slides. I think what's so important now is word of mouth. People just talking, ask people about their experience with vaccination, share your experience with vaccination. Because vaccination, honestly, is how we get out of this pandemic. So thank you again for listening, and thank you for arranging this.
Great. Thank you guys, and good night.
Okay, well, that is just, I mean, we have to give you some snaps, some claps, something to just say thank you for sharing such good information with us and really just helping to answer these questions. I'm just going to wait a second to make sure nobody has happy fingers and was just typing away a long response. But while I'm doing that, I want to say thank you so much to Dr. Kelly. And then I also want to remind you that we're going to repeat this same session at 6 p.m. So if you know some folks that just couldn't make it out today, or if you listened to it and you found that somebody else might be able to ask some questions that they didn't think they could ask, please share this with them. And also you will get a copy of a receipt for attendance, a certificate. Be on the lookout for that. But we are definitely truly thankful for you doing this for us. This was wonderful and so informative. So I see there are no other questions. So you guys are dismissed, and thank you again. And you're getting so much praise in the comment section, Dr. Kelly, so much praise.
Well, thank you. These were excellent questions. I think I'll include, I'm going to tweak my slides a little bit, to include some of the questions that were asked.
Okay.
So when we send out the slides, I'll have some of that information about, how do these vaccines made, what's the deal with the spike protein, and the more details on how this vaccine was developed. That's really come under 17 years of development, not just 12 months.
Okay, I love it. Thank you so much. And one final update is that this will be available on our YouTube station in a few days. So even if some folks can't catch it at the 6 o'clock and you still want to share it, please be on the lookout for that. But once again, Dr. Kelly, thank you so much. And thank you all for participating. And you guys can have the rest of your day. And we'll see you later. Thank you guys again.
Thank you, everyone.